Welcome again, my colleagues. This is the second nuclear isotopic scan Viva seat cases. Our first candidate, this is a 30-year-old male patient um, complaining of a neck mass. Go on. Sorry.
Okay, sir, I am presented with 30 years old patient, which is presented with a neck mass.
Sorry. Consider because there are no any history. He has a neck abnormality.
Okay.
Yes.
These are the grayscale ultrasound images through the neck, which are taken at the level of the thyroid gland. I can appreciate the left lobe of thyroid gland is normal.
Yes.
Sir, on the right side, well-defined echogenic hypoechoic lesion seen, which does not contain any internal calcification. It has well-defined margins and
Doctor,
no surrounding.
do you do you think this is the normal thyroid that usually
The
we
size is smaller.
yes? Hmm?
The echogenicity is normal, but size is smaller. Is
Side
any history of neck surgery?
no?
Sir, on left side, echogenicity of lobe is normal, but the size is smaller.
Yes. What is your differential or what's your concern?
It can be autoimmune thyroiditis.
Okay, what else?
If patient has no history of surgery, then any infection which is leads to atrophy of the gland.
Okay. What do you want to do next?
I will advise nuclear technetium 99M study for the further evaluation.
Okay. What do you think? Hello?
This
Hello?
is a technetium 90. This is a technetium 99M. Hello,
Yes, go on.
hello.
Yes. I hear you.
This is a technetium 99. This is a technetium 99M nuclear study in
Yes.
which I can't appreciate any normal uptake in the region of the thyroid gland.
See,
But there
technetium,
is
doctor, technetium bear technitate. This is very important. Okay, because technetium is the phase, and the bear technite is or the tracer, and this is the specific part of the radioactive isotope, and the bear technitate is dedicated for thyroid. Go on. Hello. Hello.
Yes, Dr. Rami, we can hear you.
Sorry, many technical problem today. No problem. No problem. Our candidate, can you start again? Hello. Hello. Dr. Nagam, next candidate, please.
Okay, please, candidate 3, proceed.
I'm candidate
Uh,
3.
Okay.
yes,
Sir, I
I'm
think this
candidate
candidate
2.
2 as well.
Candidate 2, regain online again.
I'm candidate 2.
Okay,
Yes, I'm candidate 2.
candidate 2. Okay. Uh, let's complete this case. Doctor, our last candidate find that the thyroid is very small, and then she asked for isotopic scan, technetium technitate or technitate anyway. Technitate is better. And this is the static image. Tell us what happened here.
So this is a static image of technetium 99M per technitate showing no significant uptake at the level of both thyroid glands.
Okay.
Uh,
What is this? See, doctor, to help you, this is SSN, suprasternal notch marker. Okay. So this is the region of thyroid. There are uptake here. Consider, يعني, this is the mandibular region overall. Tell me what happened.
so could be ectopic thyroid gland is seen at the level of thyroglosal duct system from the base of the tongue to the
And so your final diagnosis is
ectopic active thyroid tissue at the
at
level of the above the hyoid level.
excellent. By the way, my colleague, there must be another marker here. I think the chain marker. But anyway, I helped my colleague, and he pick up the diagnosis. This is the XF. This is the expected region of the mandible, and there are uptake. So this is means this is ectopic thyroid tissue. Where is this? This is in the region of the mandible overall. So it is almost at the back of the base of the tongue. So the diagnosis is ectopic thyroid. Thank you, doctor, so much. Doctor, could you
Yes,
tell me uh, why the ectopic thyroid is here in the base of the tongue? Why?
because this is the level of the thyroglosal duct cyst. Can be
Tell
anywhere
us,
in the
tell us in the embryological pathway of the thyroid development. Could you know it?
um,
From where the thyroid can start.
start of the base of the tongue at the level of along the thyroglosal duct cyst.
Okay. It is started from the base of the tongue. Okay. And then it is descend
Midline.
step by step till it is became in the normal lower neck position. Arresting of this process result in ectopic thyroid. Okay. Suppose the thyroid go down in its normal position. During the development process, there are a track or a tube here, okay, between the base of the tongue, then midline, hyoid, then down. Along this track, you can find any abnormalities. Tell us some abnormalities.
Thyroglosal duct cyst, thyroglosal duct sinus
Excellent.
or vestibulus.
Excellent, doctor. Thank you so much. It was ectopic lingual thyroid. Next candidate.
Yes, sir. I'm candidate number 3.
Okay. Doctor, this is a 40-year-old female patient with right hip pain and low back pain. Go on.
Okay, sir. I'm provided with the radiograph of a patient who presented with right hip pain and lower back pain. The first obvious abnormality I could appreciate is significant diffuse osteopenia noted along the right hip joint. And there are significant degenerative changes with superior and central migration of the right femoral head. Significant degenerative changes involving the pubic symphysis
One
and
second.
multiple lytic
One
in
second.
the
1 second. What's the name of this deformity?
uh, coxa magna, acetabular coxa magna.
Hmm?
Sir, I think coxa magna.
Not coxa magna. Something else.
I'm not. There is acetabular protrusion and there is coxa something. I don't remember
Not
exactly.
coxa.
حياكم الله سمعنا الكرام.
Protrusio acetabular.
Acetabular. Okay,
Why?
sir.
What is the difference between the two entities?
Sir, in the protuso acetabuli, the femoral head is migrated medial to the medial to the brim, and in the coxa magna there is just the protrusion of the acetabulum, but not the femoral head.
Okay, so see, I will tell you what I know because I confused. See, my colleague, this is a protrusio acetabuli. Why? Because the acetabulum and the femoral head, see, this line. Next candidate.
Assalamualaikum, sir.
Salam, 25-year-old female patient presented with right upper quadrant pain with abnormal ultrasound.
Okay.
Let me what.
Okay, I'm presented with the nuclear scan study of hepatobiliary system, in which I can see that of a patient with persistent upper quadrant pain, in which I can see that there is significant dilatation of the biliary tree noted, predominantly involving the intrahepatic biliary system. There is
See, there are no dilatations. This is normal.
okay, sir.
What happened for the liver here? I will help you. Don't worry.
Okay, sir.
Happened
Liver, it is
uptake.
it is uptaking the tracer.
And then excrete or not?
There is persistence of the contrast within.
No. See, just 2 minutes.
Okay, sir.
minutes.
Okay, this
There,
is
there are excretion from the hepatocyte or not here and here.
yes, sir. As compared to these images, there is it is evident that there is excretion from the liver.
Okay.
Hepatocyte.
Second, there are excretion within the biliary tract or not?
Yes, sir.
Okay. What is this?
This is gallbladder.
Okay. What is this?
These are
Gallbladder.
biliary.
Okay. If there are uptake in the gallbladder, this means the cystic duct is opened or obstructed.
It is obstructed.
No, there are uptake within the
Okay,
gallbladder.
yes. If there is uptake, then it is open and it is uptaking the contrast. Reducer, sorry.
So the cystic duct is normal or abnormal? There
It
are
should.
It is opened.
Yes, sir.
Normal or abnormal?
It is open, so it is normal.
Okay, normal.
Yes,
Okay,
sir.
what happened here? See,
Okay,
this
sir.
is scrollable. See?
This is HIDA scan, I think. Yes, sir.
Yeah. But this is adult patient. Anyway,
Yes, sir.
even suppose adult or neonate, when you see, see, gradual excretion of the tracer within the biliary tract, and then concentration within the gallbladder. What
Yes,
does
sir.
it mean? Gallbladder normal or abnormal?
It means that gallbladder is not
Not obstructed.
yes, sir. It is not it is not doing its function properly, I think.
No. Why, doctor? Why? By the way, this is a normal study. Doctor, this
Okay.
is a normal study. Okay?
Okay, sir. Okay, sir.
This is a normal study, and I start with it to explain for you.
Okay, sir.
What happened
Okay, sir.
here, my colleague? The liver started to uptake, then concentrate the tracer, then secrete. All this, see, all this, we don't have the exact time, but I think this is normal. If there are persistent contrast in the liver itself, okay, it may be due to hepatitis or due to biliary obstruction. But here it is normally excreted. Why? The density of tracer here is markedly decreased. So the liver is healthy. Second, the biliary tract start to get the tracer. Get. And then this is means no biliary tract or cystic duct obstruction till this level. Then the gallbladder start to concentrate the tracer. What is the next step? If you give the patient any heavy meals, something to contract the bladder, and then you wait, almost you will show that the bladder is completely empty from the tracer. It will contract and all the tracer go within the genome. And this is, by the way, the normal study. What happened? What happened? Concentration of the tracers in the biliary
Gallbladder.
and then gallbladder. In adult HIDA scan done for to rule out acute cholecystitis,
Okay, sir.
acute obstruction of the neck or the cystic duct. Why? Because the cystic duct is very serpentinous, very curved. Sometimes it is very hard to detect it by even MRCP. So they go to hide a scan to be sure if the gallbladder filled with the contrast. Okay, this is normal. There are no any obstruction. Look here, what happened here. Read the history well. Sorry,
Persistent
25-year-old female, right persistent right upper quadrant pain with right the most the problem is right upper quadrant pain and positive morphe sign. Despite the ultrasound is normal, but still there are a doubt about cystic duct obstruction because the cystic duct is very curved and serpentinous, and any stone within it can be missed in ultrasound.
Okay, sir.
Thank you, doctor. Next candidate. Next candidate.
Assalamualaikum, sir.
Alaikum assalam. Doctor, this is a 6-week male patient presented with hyperbilirubinemia. Go on.
Speak patient. This is a grayscale ultrasound image of a newborn. I can realize ultrasound image with the small gallbladder.
Yes,
Um,
excellent. What
and CBD is also realized.
what is this?
This is CBD, gallbladder, CBD, cystic duct.
No, see, CBD is
I
not.
think with the for the this is a thickening of the wall. I think
Okay, this is
thickened wall.
echogenic band or hypoechoic band.
Echogenic band. Yes.
Looks like
Echogenic.
linear or triangular.
Triangular, but I was confused because I can see the gallbladder. I think
See,
this
if you
triangular
meet,
ball.
one second,
Yes.
if you meet this case in the lung and you see, I will help you. This is the type of the exam exactly. DZ da DISID. Okay, and you find this ultrasound, and the patient is a 6 week and have hyperpolirubinemia. What is in your mind? Which pathway
Bilirubin.
you should go? In which pathway?
I think I would think about biliary atresia
Okay,
and
so what is
yes,
the name
go
of the sign?
a triangular cord sign.
Okay, okay.
Yes.
What is your next step?
But
Yes.
next step is the nuclear scan, the CEDA scan,
Which nuclear scan?
the CEDA or AHIDA scan.
Okay, HIDA scan.
AHIDA scan.
But see here, is this HIDA scan or not?
I think this is a different tracer, but it serves the same hepatobiliary.
Yes. Yes, we are not expert in nuclear, so this case overall is HIDA scan, and the diagnosis must be biliary atresia. Okay?
Yes.
Why?
Okay.
Why?
Because
my colleague,
because
the
there
exam
is
situation, one second, the exam situation is totally different from our practice. In your practice, you can ask colleague, you are calm, you can search in internet, and this is acceptable, by the way. The exam is another scenario, really. So you must use everything. Use expectation. Use your exclusion. Everything. By the way, this is the exact case that came in January long reporting. The same, exactly. This case. Go on. And by the way, it has some يعني atypical finding, especially in ultrasound here. Okay. Anyway,
Okay.
go on. We in that time we are not sure is this gallbladder or not, really.
Yeah,
And
but one thing I can recall, sir, that gallbladder may be present or maybe tratic is small in
maybe
related.
absent, maybe smaller. Okay.
Yes, yes, it
Okay.
can be.
And by the way, we in the exam we are not sure. We are not sure is this gallbladder or not. Something
Yes.
cystic dilated. We are not sure.
Okay.
It may be
Yes.
IVC. It may be see because the ultrasound is operator dependent. But what which item save us expectation?
Yes.
Okay. Tell us what
Okay.
happened here. Here at least.
Okay. So these are static images at 24 hours of the EDA scan.
Yes.
I can appreciate the contrast. Tracer uptake is still in the within the liver,
What is
and
it? What does it mean? 24 hours. The tracer is stick to the liver.
yeah, it should be in the small bowel, and it should be excreted into the bowel. But
Yes.
still, there is no bowel excretion, so it suggests atratic biliary channels.
Excellent.
Biliary, yeah, biliary,
Look,
yeah.
look here, my friends, at this image. This is posterior. So this is the liver, this is spleen. You should see here, the tracer is looks like this dynasty. You should see the opposite. You should see this uptake here, and the liver is photopenic
Yes,
in normal height scan. But now, after 24 hours, if you see the liver is retained يعني still catch the tracer, it
yes,
means persistence of the tracer, and you should diagnose or you should worried about biliary atresia. Okay,
yes.
no biliary secretion. Thank you, doctor, so much. It was biliary atresia.
Thank you.
Next candidate. Hello.
Assalamu alaikum, sir.
Alaikum assalam.
Yeah.
55-year-old male patient presented with right abdominal upper quadrant pain and fever. 55. And you are in reporting. You are very worried. You are sweating.
Okay.
1 second, Dr. Amir. I will
Okay.
describe the scenario. And you are thinking in everything in your life. Okay? And
Okay. Okay, sir.
it looks like what is this? This is biliary scan, isotopic scan in adult patient. Okay?
Yes.
Doctor, what's come in your mind by expectation? Which pathway you should run within it?
Sir, it's a 55-year-old male, and if
Doctor,
you view his,
your voice is not clear,
uh, sir, can you hear me now?
but not clear enough.
Okay. Try to be louder now. So, is it better now?
Yeah, much better.
Okay.
Okay. In which pathway, Dr. Omer, you should think before start?
Sir, yes, sir. Sir, keeping in view the history, age, and symptoms and the scan provided, I should think of in the pathway of cholecystitis.
Excellent.
I should be looking.
Excellent. Why I'm giving you this strategy? You must from now thinking in plan B, because the
Okay,
exam
sir.
strategy is totally different than the practice. So you must
Yes, sir.
save yourself. Okay.
Yes,
And
sir. Yes,
and
sir.
and if you is confusing in one case, especially in Viva or in long reporting, try to guess, try to expect. This is very acceptable, my friends. Okay.
Okay, sir.
Why also I'm talking like this? Because after we answer some cases, especially in wrong reporting, we are hesitated. Is am I wrong? Am I correct? And many
Yes, sir. Absolutely.
start in our mind. And by the way, this is the most destroying issue in the exams. Really, 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 in my opinion, your answer is the best for you. The first answer, you will never answer better than it. Both the answer and
Yes.
go to the next question. Long reporting depend too much in time management, and the examiner in RCR is very intelligent people. They give you a will not يعني not a difficult case, but the case is full of finding. They play on wasting your time. I remember one case. It was a metastatic, I think a metastatic. It was a CT chest, okay, and there are some metastases, and there are left breast mass, okay, and half the abdomen. He gave you a half the abdomen. Really, this case need more than 20 minutes for reporting, okay. So
Yes, sir. Okay.
so you should select the critical. My colleagues, there are one candidate. Open her mic. Mute yourself. Uh, by the way, this metastatic case, it's her abdomen contain one of the critical result. She have a يعني element of volvulus. So in the exam, you should expect and you should select which item I should report in, and which one in less details, moderate details, and more details. It is a time management game in the long reporting. Sorry, Dr. Amir, for interruption. Go on.
No, sir. These are very useful tips, actually.
Well,
Okay, sir. So I'm provided with a HIDA scan of a 55-year-old male. In this scan, I can appreciate that there is tracer uptake noted in the liver, and the excretion is also noted. However, in the provided images, I'm unable to appreciate the gallbladder.
yes.
I would like to correlate my findings with the history of the patient, and if the gallbladder is not visualized within 4 hours, then it is representing cholecystitis.
Ye-
And if it is visualized after 24 hours, then it is acute. And if it not till 24 hours, then it is chronic cholecystitis.
Okay. See, Dr. Umar,
Yes,
this is static 60 minute.
yes, yes, sir.
60 minute. 4 hours. 4 hours. According to our study, give me a differential diagnosis and see the patient. The patient has pain and fever. Give
Yes,
us
sir.
diagnosis, please.
Sir, acute cholecystitis.
Yes. Could you describe us what happened here? Why the gallbladder didn't uptake the contrast?
Sir, because it is inflamed and it is unable to uptake the contrast.
Yes, yes. See, in acute calcular cholecystitis, how can the gallbladder inflamed? What happened?
Uh,
What is
Sir, because
the trigger of inflammation?
the gallbladder is trying to push the stones, and when they are stuck in the neck,
Yes.
doing
So,
so.
so you mean there are neck obstruction?
Yes, yes.
Okay. What is the name of syndromes that may be associated with gallbladder neck obstruction?
Samirizi syndrome, in which there is a stone stuck in the neck, dilated gallbladder, compressing the
Brilliant.
CPT, and yes,
Brilliant, Dr. Omer. So it was acute cholecystitis. Better in
yes.
adult, better in adult to tell the examiner this is a hepatobiliary scan. Why? See here, what happened here? See the
Hepatobiliary
picture?
scan, yes.
Technetium colitic. I think. Oh,
So yes,
because we are not expert in young age, in neonate. Okay, hide the scan. In older
yes.
age or adult, better to tell the examiner this is hepatobiliary scan. Okay?
Okay.
Because we are so humbled in the isotopic scans, my colleague. Thank you, Dr. Omer.
Yes.
Thank you.
Thank you, sir. Thank you so much.
Next candidate.
Assalamu alaikum, sir.
Alaikum salam. Doctor, this is a 35-year-old male patient has abdominal pain post cholecystectomy. Go on.
Post cholecyst. Okay, so this is a spot film of the hepatobiliary.
Are you sure?
Okay, sir. Yes, sir. I think because there is uptake in the liver, and I can see that there is contrast in along
1
the.
second.
Uh,
1 second. This film is static Scrollable or non-scrollable?
Oh, yes, sir. I think it is
Why? Why?
scrollable.
Because first you didn't ask for control. I now I guess or I suppose that we are in the exam. You didn't ask
Oh,
for
okay, sir.
control. I
Okay.
am scrolling for you. Did you ask me to scroll?
No, sir.
Okay, go on.
Okay, sir.
What happened?
Thank you.
By the
So
way,
this is
my colleague, I make this mistake inside the exam, in the long reporting. But
oh
thanks God, I correct my situation. Go on.
right. So sir, this is image showing hepatobiliary uptake of the control of the isotope, and
Can
I
you
can see that
scroll?
there is.
Doctor, can you scroll? This is scrollable.
Yes, sir. I will try.
Yes.
Yes, it is. I'm trying.
Leave the mouse. I will scroll for you.
Okay.
Okay.
Okay. Thank you, sir. So there is.
Look from the
There
beginning.
was.
This beginning.
Okay.
What happened for the liver? What happened?
So there is a subtle uptake in the center,
Okay. Then after
and then.
uptake, it must
Yes.
excrete. Follow
Yes, sir.
the excretion, please. What happened?
Yes.
What happened?
Okay, so there is contrast excretion seen within the common hepatic
Tracer,
duct, and the,
tracer, not contrast.
the tracer, and it can be seen in the common bile duct. There is accumulation of contrast in the gallbladder.
Where, doctor, show me. Where is the common bile
Oh,
duct?
sorry, this is cholecystectomy. Yes, yes.
Yes.
So, sir, this is leakage of contrast. This is the leakage of bile post cholecystectomy.
Yes, yes. Where is
And
actually, doctor? Show me which one of those is the leakage. Yeah, first
so
of
this one.
1 second, 1 second. First of all, show me the biliary tract. I will scroll.
Okay, sir.
I will. Where is the biliary tract here?
Okay, so can you see my arrow?
Yes.
Okay, so this is this is the biliary channels, and
Okay.
this is
The biliary.
yes.
Okay. Where is the leakage?
Okay, so this is the leakage, sir, along the right lobe of the liver,
Okay.
the
And
inferior lobe.
what about 1 second? What about this one?
So this is also the contrast accumulation,
Tracer.
isotope accumulation. Sorry.
This is the tracer. Okay.
Yes, tracer. Yes, sir.
Again, what is this?
This
Tracer.
is also the leakage.
Okay, tracer or contrast?
Tracer.
Tracer.
Tracer
Okay.
accumulation.
Yeah.
Yes.
Go on.
Okay, so it is
A
there is
practical
leakage
point
of the
here.
tracer.
One practical point. Doctor, why the biliary tract is less denser than the leakage?
Sir, it has been the cholecystectomy has been done, so there is ligation over here. That is why there is the abrupt cutoff on
Okay,
this level.
give me your diagnosis.
So this is post cholecystectomy, biliary leakage, and tracer accumulation along the right lobe of liver.
My question here, how to differentiate between leakage and biliary tract? How? I will tell you.
So
See, once
okay,
I will tell you. I will help you. This
okay,
is the
thank you.
biliary tract. It go down, 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 down. Look here, my colleague. Look here. This is the bowel. If you look here, you will see. See, this is the bowel. You will see some tracer in the duodenum. So what happened? The tracer go to the bile duct and go down. But here, the tracer is accumulating. See, accumulating. No any means of drainage. So you must
Right.
see the tracer leakage denser in delayed image or in the last image. Okay,
Yes, sir.
you must see. And the other practical point. Do you remember my colleague? See, the tracer is denser and the bile duct is less denser. Do you remember in the injury of the pelvic cell system? We are telling the examiner, doctor, we will see delayed image. Why? To see the excretion. The examiner give you 5 minutes. You ask him, please give me 10 minutes, 15 minutes, even 20 minutes. Why? Because the leakage is not drained. It will persist. One of the
Yes, sir.
differential point for any leakage, no drainage, no clearance. See, see, see the bowel here. So this is,
Yes, sir.
doctor, I will ask you, if we do an MRI to detect biliary leakage or injury, which type of MRI you will do for this patient?
Sir, MRCP.
Okay. Which type of MRCP? We have two types.
Sir, heavily T2 weighted.
Okay, okay. We have two type, one with contrast and one without contrast. Secretory and non-secretory. Which
Sir, secretary.
hmm? Which one will,
Secretary.
okay, so you will use contrast, okay?
Yes, sir.
Which type of contrast?
Uh, Sir, the Primo West.
You means hepatobiliary specific. Okay,
Oh,
very good.
yes, sir.
How long it is better, the best delayed image to detect the leakage? After how many minutes?
Sir, a delayed image after 15 minutes.
This is, say, 15 to 20. This is the conventional one to detect the retention within the hepatocyte. But
Right.
I'm talking about leakage, biliary leakage. Hmm.
So, sir, on
How long?
MRI, it would be earlier.
After how long, doctor? How long?
Sir, I'm not sure.
Okay, see, this answer, I will tell you the answer after 60 minutes, 60. By the way, this
Okay.
answer I listened in Dr. Khan lecture, and you will not find in any radiology site, but it is proved. One, I think there are one hepatobiliary lecture in Dr. Khan sites. It was a female doctor, and she confirmed 60 minutes. Why? After 60 minutes, the contrast, the primovest will accumulate very well. And I think she told in the end of the lecture, this is a specific technique in her hospital. So this is a post-cholecystectomy leakage. Thank you, doctor, so much. Next,
Thank you, sir.
next candidate.
Hello, Assalamu alaikum.
Wassalam. Doctor, this patient, 40-year-old female patient presented with a right upper quadrant pain. My colleague, do you remark that most of the biliary examination today, especially adult, are females? Because biliary problem is more common in females. Doctor, what is the name of this scan?
So this is scintigraphy, hepato
Yes, yes, correct.
polyscintigraphy,
Yes, hepatobiliary scan. Okay.
hepatobiliary scan or polyscintigraphy. I can appreciate that contrast uptake and excretion is seen in the
Contrast
biliary
or tracer.
tracer uptake in the common hepatic ducts and also in the CBD right over here with accumulation. However, I'm searching for its uptake in the gallbladder.
Yes.
I think I couldn't see any radiotracer uptake within the gallbladder, either in the gallbladder or. So I am looking for its activity in the bowel. There is activity in the bowel.
What's your
So I can put mentions in this case. This could be due to cystic duct obstruction.
and
Because of cystic duct obstruction, there is no radiotracer activity seen in the gallbladder,
yes,
or other differential, less likely differential would be acute cholecystitis. However, my principal diagnosis in this case is cystic duct obstruction because
excellent,
of
excellent. So this is a hepatobiliary study. See, my colleague, very easy. My colleague, don't panic when you see different shape. This is a different shape of HIDA scan. We didn't see this movable or scrollable. It looks like reconstruction, something like this. Don't panic. Take it one by one. This is the liver. And he told you here, this is HIDA scan. So you must get some biliary or gallbladder abnormality. Look at the age. What is the age? 40. So it almost this is not biliary or 100%. This is not biliary atresia. Look, this is the liver. Liver started to secrete. Doctors, don't, all of you, don't expect this is a portal vein. Okay? Why? Inside the exam, يعني, we may confuse really. So make from now one of the very, very effective defense mechanisms against confusion and loss of confidence inside the exam, self-talk. Your back mind, train your back mind from now, one by one, in each case, in each examination. Talk with yourself. This is liver. Start to uptake the tracer, not the contrast. This is very important. Oh, there are tubular structure here. So this is biliary tract. Go down, down. What is this? Biliary tract should go here to the gallbladder. Till now, no gallbladder, no gallbladder. But what is this? It is some structure have the same color as the liver. Again, same structure connected or abutting the liver here. Oh, it looks like the duodenum. Oh, there are excretion here. Excretion. Oh, okay. Okay, see? Again, another excretion. Another excretion. See? So, no common bile duct. No common bile duct obstruction. Absent gallbladder with the patient history, with the pain, first possibility is obstructed cystic duct. Okay, my colleagues. So we must train our deep mind. We must start from now self-talk. It will help you so much in the exam scenario. Next candidate. Hello?
Yes, sir, we finished the list. If any cases, we can proceed into
Doctor,
the extra list, please.
Dr. Nagam, you can start.
Sir,
Yes.
can I attempt?
Okay, after Dr. Nagam, please.
Okay.
Yeah, Dr. Nagam.
Any history, please?
No history. What is the name of this exam? Very important. The name of the
So,
exam
technician
per
99 per technitate.
scan.
Technitate. Okay.
Is this thyroid or abdomen?
It is an abdomen and pelvic
Okay.
study.
Okay, so technician per technitate used in thyroid, but now used in abdomen. Which pathology
Okay.
do you expect we use for which pathology? We use this tracer.
Okay, we used to detect ectopic gastric tissue.
Yes, and
Yes, so this is abnormal gastric tissue presented in the pelvis.
no,
I would
not
like
the
to,
pelvis. This is the pelvis.
okay, in the lower abdomen.
Yes.
So I would like to inquire about the patient's history if he's presented with melena or low hemoglobin, because this may cause bleeding.
No,
So
no, any history of melena or hemorrhage.
okay, so this is ectopic gastric tissue. It could be
Yes. Hello?
yes.
Yeah. What's your differential diagnosis?
Okay, my differential diagnosis is it is presented like 2 feet, 2 centimeters, but I
Yes.
couldn't recall the name actually.
Yes. What's your name?
I'm trying to recall. I'm sorry.
What is the first letter of your name?
N, yes.
N. What is the letter before N?
It's okay. I'm sorry. I couldn't recall it honestly.
Yeah, I'm helping you really. You will not forget it. What is in the alphabetic order? What is before N? The letter before N.
M. Yes, M.
M. This embryonic remnant start with M.
Okay.
Hmm.
So it is.
What is this? Read this one. Read.
Nickel. Yeah,
Nickel.
Nickels. Yes.
Nickel.
Yes.
Okay. No, don't worry.
Yes, Nickels divertic. Yes.
The most important problem today is that you forget your first letter, not the forget. See my colleague.
Okay.
There's one example of the hot seat or the stress during the scenario of the exam. You can even forget your name. Don't worry.
Okay. Okay. Thank you so much.
Don't worry, don't worry. This is acceptable. It was a mecal diverticulum. It may contain ectopic gastric tissue. So this is a stomach. Okay. So it takes the tracer and this one. Somebody will ask me why the bladder take the tracer? Because this tracer looks like excreted by the kidney. Okay, my colleague. And now see, this is 40 minutes. So it is concentrated in the bladder. Don't confuse with the bladder or with the stomach. Somebody will ask me, doctor, there are no any bone, no anything to differentiate between anything. Guess, try to guess. This is peritoneate, this is abdomen, okay? And all of us know stomach take it. Stomach uptake the peritoneate. So is this or this the pathology, doctor? It looks like a bladder. خلاص, this is the pathology. Thank you, doctor, so much. Next candidate. There
So
were.
can you hear me?
Hello?
Can I participate, please?
Yes. I will explain first some information about the PET CT. This is, by the way, normal CT. Normal PET CT. PET CT. The used tracer here is F18 FDG. Fluorodeoxyglucose. Okay? Fluorodeoxyglucose. No problem. FDG. Okay, my colleague. The most important I wanted to show you the normal uptake. Laryngeal. Normal uptake. And then, because our vocal cord is continuously working. But see here, avid normal uptake in the heart. And what else? What else? Kidneys, avid. Incredible. This is the excretion, by the way, and this is the uptake. Liver and the kidney. What else? Look at the bladder, please. The bladder, due to excretion. So this is the most common avid tracer that you will find besides the brain. So don't consider any abnormality. As regard our standard in FRCR, okay, you will not, if the examiner presented one PET CT, he will not talk about this normal high uptake. Okay, my colleagues. Second point in the PET CT, they use something SUV, called SUV, standard
Standard
uptake
uptake value.
value. The normal is not more than 2.5. 2.5. Very easy. Besides this one, there are normal uptake. I think this one. Yes, brown fat, sorry. Brown fat uptake. Where is this? This is the exact location where supraclavicular,
Supraclavicular.
axillary, paravertebral. The brown fat represent 5% of our fat. Second point, it is responsible for our temperature. So, before PET scan, they make everything warm. They give the patient some medication that reduces the activity of the brown fat. Give some medication, I think it's diazepam, something like this. But finally, the PET-CT specialists have some technique to reduce the uptake of brown fat, and it is very helpful. Why? Because if you have any lymphoma here, posterior mediastinal, it will be very difficult, challenging diagnosis. Okay? Why I'm telling this long story? To destroy all of your fears about PET-CT. Very easy. And if you have been presented with PET-CT, it will be very easy. Like this. Doctor, could you tell me what happened here?
Okay, these are two selected coronal cuts of PET-CT scan of the abdomen and chest in
Yeah.
a skeletally mature patient. It shows multiple areas of avid uptake, including the
No,
both lobes of
no,
the liver.
no, not avid uptake. Increased SUV. I just said it.
Increased SUV values in
Yes.
both lobe of the liver. The areas appears to be variable in
How,
size, the
how,
largest in the right
doctor,
lobe.
one second, one second.
Yes,
How did you measure it? No. But our doctor compared these areas with the rest of the liver. Okay?
yes.
See my colleagues here? The uptake looks like the urine here, very high. Okay? What happened?
And if I measure it, I think it should be more than 2.5 as a value for the SUV
Mm-hmm.
to be considered as a malignant lesion. So these areas are concerning for multiple hepatic metastatic deposits.
Okay. Doctor, what is the name of this picture and what is the name of this picture? This first. I will help you. This
This
is
is fused, I think.
excellent.
Fused.
This is fused.
Yes.
What happened?
Yes.
CT, actual CT, and fusion with the isotopic scan, يعني the isotopic.
FDG.
Okay. Okay. So this is fused big image. What is the name of this image?
This is PET CT scan without fusion.
Yes, I know. What is the name here? This is the isotopic one, but
Isotopic,
it
yes.
has a specific name.
Um, I really don't know.
Okay, this is called MIB. Okay,
MI.
okay. So we have fused and we have MIB. Okay, my colleague.
Okay.
If you didn't retain this or keep this name, I think no problem. It is more than enough to know that this is the fused image. So, what's your final diagnosis here?
Multiple liver metastatic deposits.
Okay, and if we have the full image, we should search for primary. Thank you
Primary. Yes.
so much.
Thank you, sir.
Dr. Nagam, we have any candidates?
Yes, sir, there is one.
Okay, go on.
Good evening, sir. Can you hear me?
Yes, yes, welcome. Doctor, tell me what happened here.
Okay, this is a chest X-ray frontal projection of a skeletally mature patient in which I can say that there is a fairly defined rounded opacity noted projected over the left first rib anteriorly. I do not see any areas of calcification or cavitations or an air crescent sign in it. The rest of the lung fields appear unremarkable.
What's
The
your next
bony
step?
thorax.
What's your next
Okay.
step?
In my routine practice, if a patient presents with such an abnormality and the patient is elderly, which of course as the X-ray tells, I would first go for a cross-sectional imaging in this case.
Excellent.
And
Excellent. 1 second. What happened? Tell me, is this
okay, so
suspected malignant
yeah,
or
this is it looks like a speculated mass because it has speculations and they're going into the surrounding parenchyma. In my routine practice, I will look at the lymph nodes in this case, and also, but as this lesion is away from the rib, so I don't expect any rib involvement in this
patient
case. This
refused
patient,
biopsy? Patient refused biopsy. How can you confirm its
okay.
pregnancy?
Okay, so the next strategy would be to take the case further by performing PET staging, because that not only tells us about the primary, but it would also detect mets
What?
as less as 1 centimeter.
Tell me what happened here.
So this is a hotspot on the FDG PET scan, and although it is not mentioned what SUV unit this is, but this is more likely to be around 4 or 5. So this is in keeping with an aggressive lesion.
Yes.
In the visualized images, I do not see any other similar looking
Okay.
hot
Give me a
spot in the
diagnosis.
FDG PET.
Give me a
So
diagnosis.
this is most likely a case of lung cancer, because lung cancers avidly take the FDG PET scan. And next to
1 second.
I
1
will,
second. All type of lung cancer take FDG?
no, the carcinoids, they do not take FDG PET scan.
Excellent.
The rest of the
And what about small cell?
lung cancers.
What? Small cell?
The small cell, it also, because this is also small cell can also take because that's a neuroendocrine, so it can also take come up in the octreotide scan, but I'm
Yeah.
not very sure if the small cell takes
See.
FDG PET or not.
This is a squamous cell, by the way. Why squamous cell take uptake يعني take the tracer here FDG, and why carcinoid not take in the small cell? It depends on the metabolic activity. Squamous cell is highly metabolic activity, has a highly metabolic activity, so it take a large amount of the tracer. Okay.
Yes.
But in other neuroendocrine like carcinoid and I think a small cell, why they didn't take FDG? Because first of all, they didn't have the same activity of the squamous cell. But if we change that tracer from FDG and they bought another tracer, I think they use the tracer like used in octreotide scan. Gallium, something like this. And if you use the specific tracer for a small cell or carcinoid, it will take. That is clear?
Right. Right, sir.
FDG, my colleagues, is a general tracer for any increased metabolism all over the body, including tumors, especially cancers, and infection. Okay? This is clear?
Right.
Okay, so it is a lung cancer. It is almost a squamous cell, as I think. See, squamous cell. Thank you, doctor, so much.
Thank you.
Najam, do we have any other one?
Few in the extra list if you can continue. Otherwise, you can continue tomorrow as you wish, doctor.
Because I wanted to finish, I have 2 or 3 cases, and after that, no other lecture for nuclear, because we finish everything. We have anyone on
Okay,
the
so
list?
yes, please, I would like to ask the candidate on the extra list. They know themselves, please. Anyone can proceed. Thank you.
Can I participate?
Yes.
Okay, so I've been provided with a spot
patient,
image of us.
Doctor,
Okay,
this patient has abdominal pain. Okay, and most of the investigation were not non-inclusive. They did this study. What is the name of this study?
this is a PET CT, fused PET CT.
Okay, look here. Is this liver normal or abnormal?
This seems a normal uptake in the liver.
Okay, and the spleen, kidneys,
These are all
those
normal uptakes in the organs.
normal hyper uptake.
Yes.
Look. What happened?
So there is a significantly increased SUV in the right lower quadrant, likely in the large bowel, appears to be ileocecal junction or cecum.
Cecum.
So there's increased uptake here. So this is likely a region of higher metabolic activity, and
Okay.
this could be a malignancy given its location in the cecum.
Okay. So this is cancer cecum. Do you detect any lymph nodes? Look. Did you detect any lymph nodes? Yes or no? Any lymph node has, if you have any pathological lymph node, it must have the same uptake.
Okay.
Yes or no?
So can you hear me?
Yes.
Okay, so given this increased uptake in the cecum, I would also look for any increased uptake lymph node in the retroperitoneum and in the vicinity. I cannot see any increased SUV lymph node in the retroperitoneum.
Excellent. So
So
it is
I
not.
would suggest
Yes, no lymph node.
I would suggest endoscopy. I would suggest colonoscopy of this patient and biopsy of the cecal region and the region of high SUV.
Thank you, doctor. Doctor, what is the treatment, the surgical treatment of cancer cecum?
Sir, the treatment is right hemicolectomy. They remove the distal ileum and also the right hemicolon up to
Thank
the
you, doctor.
mid to distal transverse colon.
Thank you, doctor, so much. Next candidate.
The right hemicolectomy, yes.
Thank you so much.
Hello? Yeah.
Yes, welcome.
Um,
Doctor, this patient has abdominal pain and all the examination were non-inclusive. What is this?
okay, so this is a SPECT CT study.
PET CT. Okay.
Is
Look.
it SPECT?
No,
PET CT, yes. It's PET CT, sorry, PET CT.
PET. See, my colleague, what is the difference of PET and SPECT? In my opinion, in PET CT, you see the tracer in all organs with different degree of uptake. Look here, look. Okay, like our radiological contrast. This is a PET CT, but in SPECT, SPECT is. We have one case here before. It's very good differential point. What happened in the SPECT? I think this one. I think this. No, this. In the SPECT, what happened? Just one organ, يعني they give like this case, octreotide scan. Okay, so only one organ uptakes the tracer. They take this image and they fuse one with one CT. Okay, and besides that, the machine itself, the machine is totally different. At least, see here, my colleague. At least, the PET CT is totally different. There are FDG, there are everything in the slice is uptaking. I think we have this one. Yes. See here, all the organs, normal and abnormal organs, has tracer uptake. But the issue here is the SUV value. And second, this is, look here, PET CT. Okay, my colleague.
Okay.
If anyone know how to differentiate more about between the SPECT and the PET CT, يعني suggest some differentiation. Go on, doctor.
Okay, can you
Happened
please
here.
scroll for me?
What happened
Yeah.
here?
There is increased uptake in the greater curvature of the stomach.
Excellent.
With I think there is a mucosal thickening.
Okay, what's your diagnosis?
So this is concerning of gastric carcinoma.
Okay.
So,
Next step.
yeah, next step to check if there is any associated adjacent lymph nodes in the CT image, or if there is any increased uptake in any adjacent lymph node, and to request to check the lungs and the peritoneum for any metastases.
Okay, thank you, doctor, so much. Look, my
Metastatic
friend,
nodules.
the uptake here is more than the liver and the spleen, and it looks like the pelvic cell system. This is abnormal, totally abnormal. So it is abnormal gastric uptake It is almost gastric carcinoma. Do we have any candidate? This is last case. Hello? Hello?
Sir,
Can
can I
I
take?
Do we have any candidate?
I
Hello?
think the extra lists are not present right now. So anyone can take this case, please.
Okay.
Yes.
May I take, sir?
Okay, go
Can
on.
I do?
I need no, I need one who has not given a chance before.
Assalamu alaikum, sir. I haven't been given a chance before.
Okay, go on.
This is chest X-ray frontal projection of a young age male patient with liver masses, in which I can appreciate that the chest X-ray is showing a left lower lobe ill-defined opacity
Yes.
with the blurred margins. I would next like to see the image on the lateral view as well, and we'll proceed with the cross-sectional imaging.
Brilliant. What happened here?
There is a diffuse multiple hepatic masses with adjacent high density fluid. I can also appreciate that in the adjacent to the left cardiac margin, there is a focal of consolidation. Also, I'm expecting that in the left anterior lobe bronchus, there is an obstructed lesion
Brilliant.
which is leading to collapse of the mass. I would like to proceed with PET CT of the patient after my routine imaging to scan for whole of the any lymphadenopathy and any other suspicious metastatic node, any suspicious bony lesion, and any contralateral site lesion. I will proceed with PET CT.
Doctor, young patient, you are insisted to proceed with PET CT? Yes or no?
Sir, I'm thinking in line of that mass can be a primary of a carcinoid, which is of
Excellent.
the left
Excellent.
main lobe
Excellent.
bronchus.
Yeah, in our conventional PET CT, I just said carcinoid uptake FDG or not?
So you said no.
Excellent.
I think I remember.
So
I think it should be MIPG octreotide scan.
see, you make me an expert for the isotopic scan. My vision is correct. It is
Yes,
better to
sir.
do octreotide scan, technetium octreotide. What happened, doctor? Tell me.
Sir, there's diffuse, intense, there's a focal in uptake in the left side, which I believe is the primary, and there's a
This one.
diffuse, heterogeneous, intense tracer uptake in the left lobe, which is also extending into the liver. So this whole liver and adjacent lung part is the metastatic deposit, and the primary is that I will proceed with the facts.
Yes. Yes. See,
Or
I just was remember by the CT, extensive hepatic metastasis. Okay. And
okay,
due to this one, okay. So
okay,
your final diagnosis,
carcinoid with metastasis.
doctor, your style is amazing. Really, I'm very happy that the end of this fantastic isotopic sessions you ended. Really, your style is very ideal, and you have a so high self-confidence. Thank you so much, doctor.
Thank you so much, sir. Take care.
Thank you. Thank you for all of you. Special thank you for our Dr. Nagam. Special thank you also for other coordinator, Dr. Omer and Dr. Mega. Tomorrow, my colleague, I will start in tomorrow and the next week. I will start in fluoroscopy. I think fluoroscopy need a lot of work and a lot of sessions. Okay, I'm waiting all of you tomorrow at the same time, but please join early. Thank you so much.
Okay, thank you, Doctor.
My colleague, by the way, if you find any non-accurate information that I said in this isotopic scan, please text me, both in the group. I'm not expert or even specialist in isotopes, but I'm trying to help all of you because this branch is not covered well, even on YouTube. I search in most of of people giving Viva lecture not cover this well. Just one lecture, and they bring one consultant. Most of them talk too much about يعني beyond the FRCR exam. So I volunteer to help all of you. And excuse me if you find any non-accurate information, text me or share in the group. Thank you so much.
Thank you so much.